عملنا كورس قوي منظم كويس قوي، الاتنديز بتوعه كتير قوي. احنا كل الناس اللي عندنا في القصر العيني فرحانين بيه قوي وبيقولوا لنا ايه نفسنا نحاول نعمل واحد زيه. فيعني يا رب ان شاء الله
ربنا يكرم سعادتك يا فندم. والقصر العيني هو الكليه الام لنا كلنا، وهو المرجع الاساسي لنا كلنا يا فندم.
بس الحقيقه والله بيه يعني مجهود رائع من حضراتكم، ويعني شرف لينا وجودنا معاكم في الكورس ده.
ربنا يبارك في معاليك يا استاذنا. اتفضل يا معالي الباشا، اتفضل يا استاذ.
First of all, I'd like to thank Professor Dr. Muhammad all of the colleagues in Benha University for giving me the opportunity ان انا يعني هعرض يعني the most favorite موضوع بالنسبه لي. يعني انا اتربيت في ابو الريش من 30 سنه، واحنا يعني بنعشق حاجه اسمها السيريبرال بولسي. فيمكن يعني فرصه كويسه ان انا احاول الم موضوع السيريبرال بولسي في وقت قليل. هنحاول نتكلم within an hour عن السيريبرال بولسي which is يعني هو ده الفيوتشر اوف بيدياتريك اورثوبيدكس، وهو ده اهم موضوع في بيدياتريك اورثوبيدكس فعلا، وهنقول ليه واحنا بنتكلم. الاجنده بتاعتنا احنا هنتكلم عن حاجتين مختلفتين خالص. احنا هنتكلم الاول على السيريبرال بولسي از ديزيز جنرالي، هو عباره عن ايه والباثولوجي ايه والكلاسيفيكيشنز والنون اورثوبيديك مانجمنت اللي يعني وي شود اندرستاند واتس ذا نون اورثوبيديك مانجمنت قبل ما نفهم الاورثوبيديك مانجمنت. يعني احنا in cerebral palsy we're not dealing like in fractures femur هنعمل لها نانسي نيل، او مثلا دي دي اتش هنعمل لها اوبن ريدكشن وكابسولاريفي وديجا اوستيوتومي and this would be the end of the story. محتاجين very short term follow up او follow up يعني occasionally. احنا in cerebral palsy we're dealing with the disease هو evolving since birth. يعني احنا we're not dealing with a certain defect. It's a generalized disease affecting not the child as such but the family as a whole. احنا هنتكلم على definition على normal motor development على instance etiology. We're going to talk about the general classifications, neurological, geographical. We're going to talk about the functional classifications, the priorities that the child needs. And as I stated, it's very important to understand all the non-orthopedic management that can help the child. And lastly, the orthopedic management. First, we should answer these questions. Does cerebral palsy means mental retardation, or it has got anything to do with the intellectual ability of the child? Is it a clinical or radiological diagnosis? Is it progressive disease? As we know, the definition, it's a perinatal brain insult to the immature brain. It affects the motor development and it's associated with other problems. Literally, cerebral palsy in Arabic means shalal dimaghi. Most of the people dealing with the CP children interpret cerebral palsy as a type of mental retardation. Actually, cerebral palsy means weakness in the extremities. Shalal in the extremities. Shalal في الأطراف. Weakness in the extremities due to a cerebral cause. When we have palsy, it may be due to peripheral nerve injury, cord injury, but here it is the palsy in the limbs caused by a cerebral lesion. It has got nothing to do, the palsy is not in the brain, it's in the limbs. That's why it has got nothing to do with mental retardation. The mentally retarded or mentally affected children accounts only for about 10% of the CP children, and it's mainly due to the communication problem or due to the drugs given to inhibit the convulsions, due to the child being segregated from the community. That's why they develop some mental affection, but usually a CP child is intellectually normal. Second, we should understand what's the normal motor development. To have a normal motor development, we should have both normal motor milestone development and normal reflex development. We mean by normal motor milestone that the child has good head control by the age of 3. He should start sitting by the age of 5 or 6, crawl by the age of 9, and stand around the age of 12. And eventually he should be walking by the age of 18. He can start walking 12 or up to the age of 18. Any delay such motor milestones means that he is not here at some time and then disappears at another time, like the stepping, and asymmetric tonic reflex, the graph and change of the normal reflex development, the diagnosis that this is palsy. Diagnose CP, we should have delay in motor milestone. And the second question, very young, as 24 or 25 weeks birth children, high incidence of all of these population, they will lead to cerebral palsy. Then the more you have a developed good medical service, the more you have CP children. The etiology, as you all know, is a prenatal, natal, neonatal, or postnatal. We're not going to waste time in such issue, but you should know that the neurological classification is either spastic, which forms nearly two-thirds of the cases, and other types as atetotic, ataxic, and mixed types. The spastic CP is further subdivided geographically into diplegic patients, which constitutes half the cases. Prematurity is the most common. They are 100% intellectually normal. Eventually, they walk by the age of 4 or 5. The hemiplegic constitutes another 1/4, and they typically have some sensory problems. They have affection of the upper limb more than the lower limb. The quadriplegic patient is a severe form of the diplegic. We have severe affection of the 4 limbs, and these children can walk with aids, and this is our ultimate hope. The children with total body affection or pentaplegic patients, they have no ability to walk, they are wheelchair, and these are the patients that we should try to manage with good posturing and good sitting, and we should protect the hips, we should protect the spine, we should deal with other problems that they have, like the dysphagia, dysarthria, and drooling. The pathology of the CP is very important to understand. Although the cerebral insult does not increase, the disease itself progresses with age, which I mean that we have two pathologies. The pathology in the brain, or the cerebral lesion that causes the weakness, which, as I said, it's a cerebral palsy, is weakness. The spasticity, if it's a spastic type, and the lack of motor control. The neurological insult causes this pathology, and this is what is being understood by the neurologists. But in orthopedics, we should understand the secondary pathology, which depends on the fact that bones grow faster than spastic muscles. The bones are getting longer with the child growth. The spastic muscles can't follow the same rate of growth as the bones, and this by time leads to contracture and shortening of these musculotendineous units. This is very important to understand. When the child is born, he has the weakness, he developed the spasticity by the age of 1 year, but at the age of 3 or 4 years, these muscles are shorter than what they've been at the age of 1 or 2. These shortening or contractures by time leads to secondary bony deformities, or at least prevents the normal remodeling of the bones, like at the hip joint. By time, these deformities with the contractures and short muscles leads to the joint subluxation and eventually dislocation, which may lead to the pelvic obliquity and the scoliosis as an ultimate result. Then, a cerebral palsy child, we should understand that he has lots and lots of problems other than the weakness or the deformities in the extremities. He may have seizures. Most of them have articulation and swallowing difficulties. They have constipation. All of them has constipation. They may have UT infection. They may have visual problems. And of course, the orthopedic problems like the hip dislocations and the kyphoscoliosis. Coming to the classification, we have two very famous classifications. The most famous is the GMFS, or the Gross Motor Function Classification System, where we have them as an ambulatory or non-ambulatory. It's very important to classify them functionally, and according to this function, we will see that the management depends on these classifications. The gross motor function 1 is nearly normal. The level 2 needs some help in some motor or movement tasks. Level 3 can walk with sticks, but he may use the wheelchair for long distance walking. Type 4 can walk with the walker inside the house, but outside the house he should use a wheelchair. And type 5 is completely dependent on the wheelchair. The problem with this classification is that it's very tedious to do. It's many tasks, about 70, it was 66, then it became to be 77 tasks. We should observe the child for so long time. And that's why we prefer to use the functional mobility scale. In orthopedics, it's very simple to do. It's a 6-level scale. It's very reliable. It can be reported by the parents. Even we can do it retrospectively. We can ask the patient or the child parents how your child used to walk before the surgery 1 year ago, and now how can he walk now. It depends on what the child can do in a 5 meter, which is the home, or the 50 meter, which is the school, or the 500 meter community, which is in the club or in the street. He should report only how he walks, whether he's using a wheelchair, this is level 1, or he can walk on all surfaces, this is level 6. Of course, 1 to 6 is the space where he uses the crutches or the walker, or lastly, he uses the wheelchair. The FMS, as I said, is very reliable and very simple. If we have a child that walks in the house with a walker, then he's level 2. And in the street, he uses stick, he's level 4. And in the club, he uses a walker, then he's level 5. The management of cerebral palsy, as I said, is either orthopedic or non-orthopedic. But first, we should think about the priorities. What does a CP child need? Are we always right with taking a decision for a child who is obliged to follow his parents and sometimes to follow the doctor's thoughts? What we think is useful for the child may be not the optimal for him. For instance, if you ask a parent, what do you need for your child? He asks for walking, and then walking in a better way, and then walking in a more better way. He never thinks of the real needs of the CP child. The CP child actually first needs a good communication to develop normally psychologically, to have good behavior, to have good mood. He's a child for only 10 years. If these 10 years are lost in doing operations and physiotherapy, this is not right for him. He should have time for recreation, for learning, for everything. The second thing that he needs is being independent. Just think about a CP child. It's easier for a parent to feed his child, but it's more useful for the child to teach him how to feed himself. Okay? Then we should insist that the daily activity, as much as the parents can teach the child to do it. Then being mobile with a wheelchair or walking is not a big deal. It's a big deal for the parents. Of course, if we can make him a good walker, this is our job. This is our aim, but it should come after good communication and being independent and being mobile in the community safely, and lastly, to be ambulatory with different levels. Taking care of a CP child, we should think that it's not the orthopedists or the physiotherapist alone. There are lots of people who can help. The neurologists, the neurosurgeon, pediatrician, people making orthopedic devices to help the child is very important to CP children. Problems like spasticity could be dealt with different modalities like physiotherapy, oral medications, orthotics, Botox. We should learn all of these modalities so as to use them in certain times for certain duration. This could delay the surgery. They can improve the quality of life for the child and make him do only one surgery. But to rush to go to surgery very early may yield worse results than using these modalities. Of course, doing physiotherapy here in Egypt is something, we use physiotherapy, I think, more than we need, because a child doing physiotherapy every day for 3 or 4 hours, this is not childhood. He should know that recreation, gym training, swimming, cycling, horse riding is much better because, as I said, he will be a child only once in his life. That's why physiotherapy is important. Of course, it's very important, but for some time, and we should think of the child happiness beside to help him talk. The drugs like baclofen and sertraline has a lot to help the child, but using higher doses had a lot of side effects. That's why they started to use other modalities to deliver these drugs. Orthotics, as I said, is also very useful, but it should be tailored, and we should know that it may be heavy for the child, it may annoy him, it decreases the proprioception, and that's why it should be used for some time and not a lifetime devices. The Botox, which is very famous, it's safe, reversible, improves the function, but we should know that it should be done for certain children, for certain sites. And the most famous is the gastrosoleus spasticity. The problem is that some people use it as a treatment for life, which is not. There is some tolerance for it. It's very expensive. It can't be used when we have hip subluxation. This is a contraindication to do Botox, and also above the age of 7, which we have a better opportunity doing the surgery for the child. Also, the role of neurosurgery. Just we should know that spastic weak muscles are much better than having a flaccid weak muscles. That's why there is no role for peripheral neurectomies. When I was a resident 30 years ago, obturator neurectomy was very famous, and I think there is no role for obturator neurectomy nowadays. The selective dorsal rhizotomy is a good modality. It's very tedious. It needs neuromonitoring. The intrathecal baclofen pump is very useful. The problem is that it's very expensive. I think now we finished the non-orthopedic management part. And we're going to start with the what we can do for a CP child. What are the surgeries that we can help him? Just to remind you that before doing the surgery, we should know that this is a patient that have multiple problems. When we see the child, we can think about using Botox to delay the surgery. But when we reach a time of 5, 6, or 7, this is an optimal time for surgery. When dealing with a child, we should think about orthotics, but orthotics not for life. That's why when we have a severe flat foot deformity, we can do the surgery instead of using a ankle foot orthosis for a long time. This is not right. Then the surgical treatment, our aim is to correct a deformity, to lengthen a contracted muscle, to improve the walking pattern, to prevent deformities and joint dislocations, as I said, and of course to manage the complications like the dislocated hips, the flat feet, the angular and rotational deformities, and the scoliosis. The timing of surgery, as I said, it's about the age of 5 or 6, but you should know that when you have a hip at risk, we can go to a very early age. Also, if we have a contracture or severe spasticity preventing walking at the age of 3 or 4, we can go to surgery if we haven't got the ability to give Botox to the child because it's expensive. The classic surgery for cerebral palsy, as most of the orthopedicians know, is a multi-event surgery where we do lengthening of multiple levels, the ankle, the knee, and the hip in the same surgery. Okay, but we should know that this an example of what we can do, but we should know that it's tailored according to the patient. There is no universal surgery for cerebral palsy. We can do in some patients gastrosoleus lengthening, and in others we don't need. The hamstring, we can do it early in life, but late in life, and osteotomy is somehow better. We can do the surgery percutaneously or open, but percutaneous surgery is very nice. We do it routinely, but you should know that it needs an experienced surgeon. And one of my dear colleagues stated that to do a percutaneous surgery, you should do at least 10 open surgeries before doing a percutaneous surgery. These are different CP gait patterns in a diplegic child. The true equinus gait, the jumper's gait, the apparent equinus gait, or the crouch gait. We should know the difference between each of them. The true equinus gait, where we have hips and knees are normal. The knees may have some recurvatum, and there is only true equinus. This gait is very common in young age group, and it's much more common, of course, in hemiplegics. To diagnose a true equinus in a diplegic is very difficult, and just when you diagnose it, just delay the surgery, because doing early tendo-Achilles lengthening in a CP child, of course, leads to the famous crouch gait. The second or the most common gait in CP child below the age of 8 is the jumper's gait, where we have anterior pelvic tilt and lumbar lordosis, we have hip and knee flexion, and we have true ankle equinus. And this is the most classic CP child, where we do for them the tendo-Achilles and the medial hamstring and the abductor lengthening. The apparent equinus, where we have the same, but we have decreased ankle equinus. The foot could be pushed to be plantigrade. And in these cases, it's not advisable to do the tendo-Achilles lengthening again, because this leads to the crouch gait. As I said, the true ankle equinus is more common in the hemiplegics, and we do for them tendo-Achilles lengthening. The jumper's gait could be managed with buttocks very early, and above the age of 5 or 6, we can do the single event multi-level release. If buttocks is not available, we can do surgery as early as 3 or 4 years. The crouch gait, commonly seen above the age of 8, and it's commonly seen after over-lengthening of the tendo-Achilles, where we have hip flexion, knee flexion, and ankle dorsiflexion. The increased knee flexion throughout the stance phase due to disruption of the ankle plantar flexion knee extension couple is the cause of this crouch gait. It's a very clumsy gait. It's commonly associated with severe planovalgus foot. In a crouch gait, we should assess the level of the patella, and we should assess if there is passive knee extension. If we have a passive knee extension, and a ground reaction force splint may help a lot. But if the passive knee extension is lost, which is very common, we should go to supracondylar femoral osteotomy. We may need to do medial hamstring release, but the problem is that when we do a medial hamstring release with the crouch gait, this increases the pelvic tilt. That's why a lot of people advise not to do the hamstring release, but to do a supracondylar femoral osteotomy alone, and this increases the knee extension without weakening the hamstring, but it also puts more tension on the hamstring, improving the pelvic tilt. If we have a patella alta, we should tighten the ligamentum patelli. We have different techniques for this, but this is very important as it improves the knee flexion as well as the quadriceps mechanism. The percutaneous osteotomy, whether to be done percutaneously and fixed in a cast, or use a peeling cast technique, or K-wires or plates, all of these modalities is acceptable. In my hostel, we do it 100% percutaneously without any fixation, and it's very safe. But you should take care, because when you have severe knee flexion, it's important not to correct the knee flexion in one time. You should correct it gradually. Otherwise, you may have sciatic nerve palsy, which we had several cases when we tried to do acute correction of a severe knee flexion. This is different techniques for supracondylar femoral osteotomy. Concerning the stiff knee gait, which is very common in children, they're good walkers, but they can't do good clearance of the foot while they walk because of the overactive overfiring of the rectus femoris. We should do a rectus release or rectus transfer. We should know that the aim of rectus transfer to the semitendinosus is not to improve the knee flexion by the rectus acting as a flexor, but we transfer it mainly to be sure that it will not reattach again to its original attachment and having the same problem again. Which I mean that the transfer functions to prevent reattachment of the rectus femoris, much more important than to act as a flexor at the hamstring level. The rotational deformity, I'm sorry if I'm jumping from one topic to another topic, because of the very tight time. It's a very difficult subject to have it on only 1 hour, but the rotational problem is one of the most important problems to correct in CP children. Correcting an internal rotation deformity in the femur improves a lot the function of the child. We had a study where the children, after the osteotomy, the motor function improved a lot. The number of falls improved a lot just by correcting the femoral anteversion. Also, the external tibial torsion should be corrected because the external tibial torsion makes the gait very clumsy. Just when we correct the external tibial torsion, the child is walking more rapidly. We published a paper about evaluation of the functional outcome of percutaneous technique and correction of femoral anteversion in Pediatric Orthopaedics British this year. This is how we measure the angle. We have severe internal rotation, limited external rotation. We ensure our clinical examination with the CT. The technique is very simple and very reliable and very rapid. Just we do 2 Shan spins at an angle. The angle here is equal to what we need to correct. If it's 40 degrees, then this makes an angle of 40. If it's a 50 or a 30, according to the angle diagnosed preoperatively, we put these 2 pins, one above the physis and one higher, and then we do a percutaneous osteotomy. We break the bone after multiple drills and using the osteotome with a rotational torque. We flex the knee and we rotate the limb externally till the pins are parallel, and then we corrected the exact amount that we need to correct the rotation, and then we apply an above knee cast. This is a very simple surgery that would be combined with multi-level release, with hip correction, or with foot and ankle correction. That's why it's a very simple technique. It's a very simple technique. Another problem very commonly seen in cerebral palsy children is the severe planovalgus foot. It causes a very clumsy gait. It may cause callosities and ulcers, and that's why it should be corrected. We can't use an AFO or an insole for life. In 2016, we published a paper about calcaneal lengthening osteotomy, but I think it's much more better in CP children to do arthrorizes. We use different screws for the arthrorizes. First, we use the calcaneal screw. It's perfect, but the problem with the calcaneal screw that it needs some technique. Most of the junior surgeons in our university do it in a wrong way. But if it's properly seated, it's the top result arthrorizes for cerebral palsy children. Then we use a blocking screw or the sinus tarsi implant. The problem with that it moves in normal children, it's okay, but in CP children, it's not very stable. That's why we use this screw. It's rectangular, and it gave better results in CP children because it doesn't move with the abnormal movement of the CP children. Lastly, the most important topic today, and I'm sorry for being, it's the last topic we're going to talk about, is the hip problems with cerebral palsy. Hip problems with cerebral palsy is the most common missed problem by the pediatricians, the physiotherapists, and some of the orthopedicians. There is a very strange debate. Most of the orthopedic surgeons say that being a non-walker doesn't necessitate that we correct a subluxating or dislocating hip. And this is completely wrong again. We should know that hip subluxation correlates a lot with the motor function. The more the child is a non-walker, the more that he will have a hip problem, and the more he will be in need for surgery for his hip problem. Okay, then when we have a gross motor function level 1, mostly he will have a good hip. And having gross motor function grade 5 is a wheelchair. Most of these children will have hip problems that necessitates to do surgery. Why does this hip problem happens? It's because the child is born with a normal hip. During development, he has spasticity and tightness of the adductors and of the iliopsoas. This prevents normal development and prevents normal remodeling of the hip due to the child is not a walker. Then he has persistent excessive femoral anteversion and persistent coxa valga. These two factors by time pushes the hip outside of the acetabulum with growth. We're saying that the hip is migrating outside. Originally at birth, it was well located in the hip, but the problem is that when the child is at 1 year, 2 years, he's okay. At 3, 4 years, the hip starts to migrate outside the hip. If left untreated, it turns to be completely out, dislocated. This dislocated hip is severely painful. It causes pelvic obliquity, and if not corrected at the proper time with development, this leads to scoliosis. That's why a subluxating or dislocated hip should be treated. And as I said, it's mostly common in the non-walkers, and it should be corrected and treated. This is the Reimer migration index. We just drop a line at the lateral edge of the acetabulum, and we calculate how % of the head is outside. We say that it's 25% outside the acetabulum, it's 50, 60 accordingly, and this is the Reimer migration index. The management of the CP subluxating or dislocated hip basically is, of course, prevention. We should try to do repeated abduction exercise. We should lengthen an already tight abductor. When we have limited hip abduction less than 45 degrees and the Reimer migration index is only 33, this is an indication to do abductor release plus iliopsoas and hamstring lengthening. Just we do this to prevent hip subluxation and then dislocation. Of course, as I said, obturator neurectomy is not advisable. When we have the Reimer migration index more than 33 degrees with persistent subluxating hip, we should go to varus derotation osteotomy and pelvic osteotomy. It doesn't matter, a digger, Pemberton, Salter, according to the surgeon preference. Okay, but we should relocate the head as early as we can. If we have something like this, it's a completely dislocated hip, it's a frank dislocation. The Reimer migration index is 100 now. We should do a soft tissue release, a varus derotation osteotomy. We may need to do some shortening and, of course, a pelvic osteotomy. Something very important to know that in some patients with delayed or neglected hip dislocation, they develop abduction deformity on the contralateral side of the dislocation. At these children, we should do what we call balancing of the pelvis, where we should relocate the dislocated hip as well as we should do abductor release on the contralateral side to balance the pelvis. Keeping the contralateral side with a fixed abduction deformity will make the side of the operation fail. And a lot of children coming to our university with failed hip surgery, they do subtrochanteric varus and digger osteotomy and soft tissue release, and the surgery fails. The main of this failure is most probably due to the unattended or untreated abduction deformity of the contralateral side. That's why we should keep an eye on the contralateral side of a dislocated hip. This is how the hip develops in a CP child. Here it's well located, and at the end it's completely dislocated. This is with age, of course. How do we do a subtrochanteric varus derotation osteotomy? It's something interesting. It could be done with a plate, which is the most common, fixed angle plate, of course. But in our university, we had a very simple and nice technique. Just we do a percutaneous osteotomy with a monolateral fixator. It's a very rapid surgery. It takes something like 15 minutes. There is no blood loss. And of course, it could be combined with other surgeries. As I said, the surgery, after doing such operation, he doesn't feel tired. He can continue to do both sides if both are dislocated and to do other surgeries. Also, it's very nice in osteoporotic bone. This is how we do it. It's a child with a subluxating hip. We just did subtrochanteric varus and derotation osteotomy. The derotation is very important because the excessive femoral anteversion is a cause of the subluxation dislocation. Of course, we do some lateral translation of the distal fragment. And this is how the child looked after 1 year. The head is well located, even the acetabulum remodeled a bit due to the varus that we did for him. Of course, it's not wise to leave a child like this. He has severe cachexia. He's underbuilt. He has neglected hip dislocation on this side and abduction deformity on the other side. This is classically, we should not rush to surgery upon seeing this child. We should first improve his general condition through a ryle to feed him, or much better to do a gastrostomy to feed him until he built up some good health, and then we should go to the surgery, as I said, a subtrochanteric varus derotation osteotomy with a pelvic osteotomy and correction of the other abduction deformity if it's fixed. Just remember, concerning the hip problem, that physiotherapy has no role, and that the subluxating hip correlates a lot with the function. It's more in the non-ambulatory children. Hip surveillance is very important, that we should do an X-ray in every CP child during his growing time, especially in non-walkers. The only hip that needs no treatment, if it's dislocated, is the rare hypotonic subluxed hip. Thank you for giving me the time to talk a lot about the CP hip, but I think we have to remember that although cerebral insult doesn't increase, but the disease progresses with age due to the fact that the bones grow faster than the muscles. We should use something like the functional mobility scale in our evaluation. It's much easier than the gross motor function classification. We should know that there's lots of modalities to manage the child, and the surgery should be postponed as much as we can. The treatment, there is no universal surgery in CP children, but the treatment is tailored according to the patient's problems. Physiotherapy and orthotics may help for some time. Botox and baclofen is the same. There is no role for neurectomies, which were famous years ago, but unfortunately it's still done by some neurosurgeons and some of our colleagues in orthopedics. The multi-level surgery should be done simultaneously. We should keep an eye on the hip, because the hip is one of my professors used to say it's the hidden problem in orthopedics in all diseases. In the hip, it's hidden as a DDH, it's hidden when it's perfect, it's hidden when it's scaphy, it's almost missed. And in the CP, it's almost always missed by the doctors, even with the orthopedicians. When they discover it, some say that we don't have to do surgeries for them, which is completely wrong, as I said. Take care not to lengthen the tendo-achilles alone in diplegics, or you can have a crouch gait. Lateral hamstring is not needed in most of the cases, or in all of the cases. It's enough only to do a hamstring, medial hamstring release. And in older age, it's preferable to do an osteotomy than to do a hamstring release to prevent excessive flexion deformity of the pelvis. Correction of angular artificial development is very important. It helps the child a lot and improves the quality of life. It could be done percutaneously with a very simple technique. Also, correction of flat foot helps the child a lot, and it's advisable to be done whether by calcaneal osteotomy, subtalar fusion in severe cases, or we prefer to do arthritis. Sorry for being too long, but thank you.
Thank you so much, our beloved Professor Hassan El Barbary, Cairo University, for this interesting talk that summarizes all the hip problems in CP child. Thank you so much, sir. It was very nice talk. Thank you so much. Our moderator will be with you, Professor Ahmed Allam, Benha University, and one of the experts in our university in CP and pediatric orthopedic surgery and deformity planning surgery. Dr. Ahmed? Dr. Ahmed Allam? الدكتور احمد كان معانا دلوقتي، واضح ان عنده مشكله في النت. انا هبقى مع سعادتك يا فندم. هو اول سؤال سعادتك how to manage recurvatum knee gait post hamstring lengthening with lumbar lordosis and pelvic anteversion.
This is very
from Dr. Muhammad Wael Saddiq.
This is a very nice question. It's really very common to see recurvatum after surgery. First, we should know why does this recurvatum happen. Is it due to over lengthening of the hamstring, as most of the patients or the physiotherapists or lots of the doctors say? I don't think so. The main cause of this recurvatum is that these children has originally hyperlaxity and they have tightness of the tendon Achilles. Just when we do lengthening of the hamstring, we uncover this recurvatum. Okay? If you examine the child preoperatively, okay, he has hyperlaxity. You can anticipate that this child would develop some recurvatum. Okay, then if you find the recurvatum postoperatively, first search for tight tendon Achilles. If it's found, then you should correct. The next thing is that you can use the orthosis, which is the anti-recurvatum orthosis, for some time. It gives very good results. But you should be sure that this recurvatum is not always due to over lengthening of the hamstring. Especially, we never lengthen the lateral hamstring. We lengthen only the medial hamstring. Okay, and I haven't got good time to explain that when we're doing the multi-level surgery, we're doing balancing in different levels. When you're doing medial hamstring lengthening, you should correct a tight tendon Achilles. Otherwise, a tight tendon Achilles will lead to this recurvatum.
Yes.
I hope I answered the question.
Yes, sir. Professor Ahmed Alam معانا دلوقتي.
اهلا وسهلا.
اهلا بيك بيه.
دكتور احمد علام, one of the experts of CP in our university, sir. اتفضل يا دكتور احمد مع الدكتور حسن بيه.
دكتور حسن بيه, انا اسف ما جاتليش فرصه ارحب بيك في اول لقاء, بس انا متابع المحاضره من اولها. ما شاء الله محاضره عظيمه اكثر من رائعه.
ربنا يخليك. انا بشكل
حاجه هايله بصراحه. تسلم ايديك يا فندم. ربنا يخليك.
ربنا يخليك. انا شاكر لحضرتك.
ربنا يخليك. في سؤال من زميلنا الدكتور احمد عبد المنعم. How can you control the knee rotation osteotomy percutaneously?
Okay, here simply this percutaneous osteotomy is a very inherently stable osteotomy. Okay, it's stable with two modalities. First, the osteotomy technique, and then we use the pin and cast technique. The pin and cast technique is an old technique where we used to fix the fractured tibia with the pin and cast technique. Okay, we had the same technique. We do multiple drill holes percutaneously. The soft tissue envelope of the femur is completely normal. We do the osteotomy very low. It's a very broad part of the bone. Okay, and we do the osteotomy. We complete the osteotomy not by varus or valgus or something like this. Just when we do multiple drill holes, we do corticotomy of the two nearby cortices only. And then we flex the knee, we rotate the hip externally with the knee, and we feel the crack and the pins turn to be parallel. This is the end point of the osteotomy. Okay? And then we do the cast. We never had any instability in such cases, following the technique in a proper way. It's a percutaneous osteotomy, multiple drills, osteotomize only the nearby cortices, and just break the bone with the rotation movement of the knee, and then the pins are parallel and you do the cast. And this should be done, of course, after all the soft tissue release that we need is done. Okay, and if we're planning to do in the same session a hip surgery or ankle arthritis, this should be done before the osteotomy.
Yes, another question from the same Dr. Ahmed Al-Imam. My question, sir, is about containment of the head of the femur. How can you contain the head of the femur, sir?
Okay, if the head is only subluxed, where the Reimer migration index is about 50 or 40, we do in younger age group iliopsoas, abductor, and hamstring release, and this is more than enough at this age. After the age of 5 or 6, it's advisable to combine with it a subtrochanteric varus derotation osteotomy, where, as I said, we prefer to do it with a fixator. It's very simple. It's a 15-minute surgery for both sides. Okay, just we do subtrochanteric varus and lateralization of the distal fragment, and that's all. We can add DEGA osteotomy. Some surgeons don't do it. I don't do it. At this age, only subtrochanteric varus derotation osteotomy, and the hip remodels. The varus push inside will develop good acetabulum. Some may add DEGA. After the age of 8, we should do a pelvic osteotomy. Okay. If we have true dislocation, we can add shortening, of course.
I don't see any other questions, sir. Another question for دكتور عمرو عزام. مرحبا دكتور عمرو عزام، اهلا بحضرتك يا فندم. طبعا شرف لنا ان دكتور عمرو بيه معانا النهارده. سؤال دكتور عمرو بيه لحضرتك دكتور حسن باشا. What can we do or is there any solution for the iatrogenic Achilles tendon lengthening in CP patients as I face this problem many times?
هو حضرتك برضه this is a very nice topic. يعني احنا حضرتك الحمد لله يعني at my university we're trying to solve most of the problems. Okay, the over-lengthened Achilles tendon is very commonly seen in severe crouch patients. Okay, correcting the crouch gait, as I said, by supracondylar femoral osteotomy, lowering the patella if we have a patella alta. This is the start of the correction of the over-lengthened tendo Achilles. We should not correct the tendo Achilles and neglect the knee. We should start with the knee, and after the knee is completely corrected on table, it's as I said, it's single operation. We can re-tighten the tendo Achilles. It's my technique, and I'm trying to publish it these days. I've been taught this technique by Professor Dr. Ahmed Abdelaziz, the great knee surgeon. He do a percutaneous repair of the tendo Achilles rupture. I think most of the orthopedicians know the technique of Dr. Ahmed in the repair of the tendo Achilles rupture. Okay, I adopt the same technique in shortening of the already lengthened tendo Achilles rupture. I'll send to Amr a video of how I do it. It's very simple. We get a tape or a good suture, a 5mm suture, and we go with the needle percutaneously through the tendo Achilles. Of course, we start by correcting the knee, then we do lengthening of the already shortened ankle dorsiflexors percutaneously, of course. Then we do tightening of the tendo Achilles percutaneously using a needle and a tape or suture 5mm. We go through the tendo Achilles while the assistant keeps the ankle in complete plantar flexion. And we go like this through the tendo Achilles with good tension, and at the end we tighten it in a shorter way. Okay, it's the same as repairing an already ruptured tendo Achilles, but we don't have the ruptured tendo Achilles. We go through the whole tendon and we make it more tight using this tape. At the end of the surgery, we can see the ankle clonus again. Okay, if we were using something like total intravenous ketamine anesthesia, just you put some dorsiflexion, you see the ankle clonus again, and this is an on-table success of repair of an already over-lengthened tendo Achilles. I hope Dr. Amr can get what I mean.
لو سمحت يا دكتور حسن، استفسار مني أنا. حضرتك أنت شايف how much convenient to fix a rotational osteotomy or hip reduction in a CP patient? How much it is convenient to fix it with an external fixator؟ يعني معظم العيانين دول بيبقى البيت كير بتاعهم صعب، وبرسنت كبير منهم فيهم mental retardation، فيبقى عندي factors against الكير بتاع الاكسترنال fixation. From your experience, how much it is convenient to do it without internal, but you do it with external fixation and rely on it?
First of all, most CP children are intellectually normal. Okay, I'm sorry for this. Okay, they are intellectually normal. They are not mentally retarded. The second thing is that to fix it with a plate this is the classic, and this is right. This is 100% right. Most of the surgeons all over the world fixed with a plate. It's the classic. Okay, why we do it with a fixator? We do it with a fixator just because it's more easy for the doctor and easy to combine it with lots of surgeries in a CP child. Okay. Also, it's this fixator is versatile. You can increase or decrease the angle after the surgery. Okay. For the care of the child, it's more easy. It's more safe to have a fixator than to put him a cast. These children are usually not young. They are about the age of 8, 10, 12, 15. Okay. These ages are very difficult to put in hip spica after the plate. Okay, and it's not secured by the plate. If you put a plate, I think you need to put him in a spica. But the fixator is 100% secured. You can't lose the reduction. The monolateral fixator, you adopting a percutaneous technique, the bones are inherently stable after this osteotomy. And just when you do the correction with the fixator, it's stable. I know that most of the patients feel that the fixator is more annoying than the plate. Okay. In my university, some of the surgeons use what I use is the fixator, and a lot of them use the plate. It's the classic.
Yes.
Yeah. I think the plate is more convenient, as you said. The problem is that I like fixators.
Me too, like fixators. I am mainly a external fixator worker.
Me too.
But I am asking about the tolerance for the patient and the bed care. This is the point, because he is not a normal patient.
No, I think the care with the fixator is easier. There is no cast. The child can even start moving after 3 or 4 weeks. Not walking, of course, but he can start moving.
Yes. شكرا جزيلا. في معانا سؤال ثاني يا دكتور محمد؟
ايوه يا فندم، هو في سؤال لسعادتك دكتور حسن بيه من دكتور شركاوي عبد الباقي. Please, what's the indications of only derotation osteotomy, as usually we need shortening and derotation as well as at the same time?
I don't understand. Does he mean derotation at the hip or derotation osteotomy at the knee, or I mean
at the hip, sir. Only derotation osteotomy without derotation and shortening.
Okay, just derotation is needed.
Just derotation.
When we have excessive femoral anteversion. Okay. Yeah. In our paper that we published this year, it was published in 2020 April. It states that the functional outcome of the child improves a lot concerning the gait, the feeling secure, the number of falls. Everything improves a lot after a simple derotation osteotomy. Okay, the child with excessive femoral anteversion falls a lot. This is an unstable position for the child. Okay, just when the femurs are having severe excessive femoral anteversion, he's looking like having knock knees. Okay, and this pushes him to fall to the ground several times or being unstable. A very simple uneven ground would lead him fall. Just when we do him a derotation osteotomy, the most drastic change that the parents feel is that he never falls again, just after derotation osteotomy. When to do it? When just when you examine a child, look him from while he's coming to you. If he has an internally rotated knees, this is an indication to do a derotation osteotomy. What's new is that we used to do it above the age of 8. And when we felt that it has changed a lot the quality of life of these children, we turned to do it younger than this, much younger, even at the age of 4 or 5. The problem is that it remodels back to be internally rotated again, and we may redo the operation. But being very simple, we can do it very early.
لو وقت حضرتك يسمح ب other 2 questions يا فندم.
طبعا مستمتع جدا بالاسئله.
هو طبعا يعني كثرة الكويستشنز لجمال المحاضرة ولعظم المحاضر.
يعني انا مش عارف اشكر حضرتك ازاي.
ربنا يخلي سعادتك يا فندم. Another question from Dr. Sharkawi also. Only fixator serve for femoral osteotomy in spastic patients. What's the frequency of refracture?
يعني احنا we did this operation or this type of surgery maybe for 10 years now, and we did a study that ended up in 2018. It included around 70 patients, and we had never a refracture. The problem was that we had some patients with still subluxated hips, okay? And that's why we should go to pelvic osteotomy, because as I said, sometimes we don't do pelvic osteotomy. And from this study that we ended up in 2018, we learned that above the age of 5 or 6, this is the maximum age that you can do the subtrochanteric varus derotation without pelvic osteotomy. At the age of 8, you should do a pelvic osteotomy together with the subtrochanteric varus derotation. Of course, with the soft tissue release.
Another question, sir, from Dr. Muhammad Ahmed. Can we assess degree of anteversion clinically without CT scanogram?
Sure, we can do it with more than one modality. The most simple is that when the child is lying on his back, see the external rotation range and the internal rotation range, and this is very simple. To be more accurate, turn the child on his face and just flex the knee. It was on my slide. Just you see the child take the range of external rotation and internal rotation. Excessive femoral anteversion, it means severe or increased degree of internal femoral rotation with severe decrease in the external rotation. This is the clinical way. Lots of things. You can just feel the greater trochanter and the maximum prominence. This is the neutral position, and then look at the knee where it points. This is a third way. In our study, we used the sonar, and it showed that it's very accurate. The sonar is more or less like what we do in the clinical examination, but it looks at the hip and the knee, at the neck and the knee in the same time.
Yes. The last question, sir.
يا دكتور أشهب.
اتفضل.
دكتور محمد أشهب، في عندنا يوسفول جايد برضه اللي هو استهلي روتيشنال بروفايل. ده very well clinical guide for measuring of anteversion and limb rotation generally. والعيان سوباين والعيان برون. استهلي روتيشنال بروفايل ده هايل في الكلينيكال ايفالويشن.
هو الاكسترنال تيشو بروفايل حضرتك انا حطيت السلايد بتاعه.
حضرتك حطيت السلايد اوريدي يا فندم.
انا عامله كلينيكال، يعني ده حضرتك اللي هو الاستهيلي how استهيلي measures the rotation profile the patient lies on his face and we see the external and the internal rotation range.
تمام.
The last question for you, sir, from Dr. Emil Awad. Dr. Emil بصراحة من الناس اللي حاضرة معنا الكورس من أوله فبنحييه. What's the best operation for dislocated hip to prevent redislocation or migration of the femoral stump, sir?
هي as I said, it depends on the degree of the deformity and on the age. If the Reimer migration index is mild and the age is very young, we can do only adductor and iliopsoas and hamstring. The hamstring is very important, of course. Okay, if the migration index is above 50 and the child is still young, 5 or 6, we can do subtrochanteric varus derotation osteotomy with the soft tissue release. Above the age of 8, we should do a pelvic osteotomy too. If there is frank dislocation, of course, we can add shortening.
Yes. Thank you so much, sir. احنا خدنا من وقت حضرتك كتير دكتور حسن بيه. احنا استمتعنا بوجود سيادتك النهارده واستقينا من علم حضرتك الغزير يا فندم.
ربنا يخليك.
شاكرين افضال حضرتك وتشريف حضرتك يا فندم.
Thank you very much.
شكرا جزيلا دكتور حسن بيه، كتر خيرك. شاكرين يا فندم. شكرا جزيلا.
شكرا يا فندم. بوجود سيادتك يا استاذنا.